All right, team, let's get into it. We're going to talk about sepsis. But listen, this is not another one of those boring lectures telling you everything you're doing wrong. This is for us, for the people at the bedside. This is a practical, no-nonsense look at how we win the war against sepsis in the place that matters most, that very first hour.
And I am not kidding when I say that. The second you even think the word sepsis, a clock starts ticking. This is not just another problem to work up. It's a full-on declaration of war. An infection has thrown the body into total, unregulated chaos, and everything we do in that first hour, well, it can be the difference between a patient walking out of here or not.
So where does this all begin? Before you can fight, you have to recognize the enemy. And let me tell you, sepsis can be sneaky. It's not always going to be the screamingly obvious patient with a sky-high fever and a blood pressure in the toilet. You have to learn to trust that feeling, that little voice in your head that says, something's not right here.
I'm talking about the patient who doesn't quite fit the textbook picture, at least not yet. You know the one. The 45-year-old who just looks kind of pale, a little washed out, and says they feel weak. Or the elderly patient from the nursing home whose only new symptom is that they're suddenly a bit confused. Yeah, we have tools like the Muse score that help flag these patients, and that's great. But really, it all starts with your eyes, your experience, and your gut.
Look, let's be real. This isn't what you see on TV. The sickest patients don't always roll in like a massive STEMI with those giant tombstone-like elevations on the EKG. That's the easy stuff, the Hollywood stuff. The real work, our work, is spotting the patient who is quietly circling the drain and getting ahead of it before they crash and burn. That gut feeling of yours, it is one of the most powerful diagnostic tools you have. Trust it.
Okay, so you've spotted the enemy, you've trusted your gut, you've called the sepsis alert, and now that 60-minute clock is officially ticking. So, now what? Now we fight back. And the good news is we have a clear, evidence-based playbook. It's called the Hour 1 Bundle. This is our roadmap to victory. And look, anyone can memorize steps, but really, truly understanding why we do what we do, that's what's going to keep you calm and effective when all the alarms are going off.
And here it is, the playbook, our 5 core maneuvers, the game-winning plays. We're going to measure a lactate, get blood cultures, hang some heavy-hitting antibiotics, slam in a fluid bolus, and then if we have to, we'll start squeezing with vasopressors. So let's dive in and break down each one of these.
All right, first things first, we need intel and we need to go on offense, like right now. This part is all about labs, bugs, and drugs, getting the right information, figuring out what we're fighting, and getting the right weapons on board as fast as we possibly can.
Let's start with lactate. Think of a high lactate level as smoke coming from a fire. It is a direct signal from the patient's cells that they are suffocating. See, in sepsis, because of the low blood pressure and leaky vessels, oxygen just isn't getting delivered to the tissues. So the cells, in a desperate move, they switch to a backup plan called anaerobic metabolism. They're trying to make energy without oxygen, and it's super inefficient and creates this toxic waste product, lactic acid. A lactate over 2 is literally every cell in the body screaming at you, hey, we are not getting enough oxygen down here, do something.
Now, before we do anything else, we got to get blood cultures. And this is so important. They have to be drawn before the antibiotics go in. Think about it this way. The big, broad-spectrum antibiotics we're about to use are like a giant trolling net in the ocean. They catch a whole bunch of different stuff. But the blood cultures, they tell us exactly what kind of fish we're after, so that later we can switch to a tiny goldfish net and target the specific bug. If you give the antibiotics first, you destroy the evidence. Poof, gone. You get one shot at this.
And this, right here, this is why we move with purpose. For every single hour you delay antibiotics in a patient with septic shock, their risk of dying goes up by almost 8%. Just let that sink in for a second. An 8% increase in mortality per hour. A couple hours delay, you've just tanked their chances of survival. This isn't time as brain like in a stroke, this is time as life.
So here's the bottom line. The infection is a fire that is raging out of control inside the patient's body. The broad-spectrum antibiotics, that's your fire extinguisher. Our job is to pull the pin and just spray it everywhere. We need to put the fire out now. We can figure out exactly what started it later, once those cultures come back, but right now, the priority is stopping the destruction. Okay, the fire extinguisher is going. Now we've got to deal with the damage, the fallout, and that is the hemodynamic collapse, the shock. This is where we bring in the heavy artillery. We're going to fill the tank with fluids, and if needed, squeeze the pipes with pressors.
So what is actually happening to cause the shock? Well, the body's crazy inflammatory response releases all these chemicals that cause massive vasodilation. Basically, every single blood vessel in the body just gives up. They get wide, floppy, and permeable, which means fluid starts leaking out everywhere. Imagine your entire circulatory system turning into a giant leaky fire hose. Of course the pressure plummets.
So, what's our first move to fix this? We pour fluid in. A lot of it. The standard is a 30 milliliter per kilogram bolus of crystalloid, and this does two really important things at once. First, it literally just refills that big, floppy, leaky system to try and get some pressure back. And second, all that fresh fluid helps dilute and wash out that nasty lactic acid we were talking about.
But, and this is a huge but, you can't just be a hang-it-and-forget-it nurse. Fluid is a drug, and you can absolutely overdose a patient on it. You have to be right there at the bedside, constantly reassessing. Put your stethoscope on their chest. Are you hearing new crackles? Is their O2 sat starting to dip? This is especially true for your classic CHF and renal patients. You can push them into flash pulmonary edema in a heartbeat if you're not careful. So, you've slammed in the fluids, you're reassessing, and you look up at the monitor. And that mean arterial pressure, the MAP, it's still at what I call pucker level. It is well below 65. That's the moment. That's when you know that fluids alone are not going to cut it. The tank might be full, but the pipes are still too floppy. It's pressor time. Our workhorse is usually Levofed, and it's great because it gives you two things for the price of one. It gives you a powerful squeeze on the blood vessels, which jacks up the blood pressure, and it gives the heart a little kick to help it pump more effectively. Now, if you find yourself cranking the Levo up and you're still not getting to that magic MAP of 65, the next play is usually to add a second pressor, like vasopressin. It works differently, so it's like attacking the hypotension from a whole new angle.
Okay, let's have a very real, very serious talk about pressors. This stuff is liquid gold inside the vein. But if it gets outside the vein, it is incredibly destructive. It's tissue toxic, and infiltration can cause horrible tissue death, necrosis. Now, yes, we all know the goal is to run it through a central line, but we live in the real world of the ER. We're going to have to start it in a peripheral IV first.
So, if you're going to start pressors peripherally, you had better know your hospital's policy for infiltration, and you must know the antidote. That's phentolamine, or Regitine. And don't just know its name, know where it is. Have it ready. Look, letting a patient stay hypotensive is far more dangerous than the risk of an infiltration. But that does not give you an excuse to be careless. You need to be checking that IV site like a hawk.
So that's the battle plan. We've covered all the moves and, more importantly, the why behind them. But let's be crystal clear about something. None of this happens without you. Sepsis care is a team sport, for sure. The docs, respiratory, and especially our pharmacists, who are absolute lifesavers. But the ER nurse, you are the engine that drives this entire operation.
That's really the bottom line, isn't it? Who's the one that gets that first gut feeling that something's wrong? We are. Who's getting the IV access, drawing those crucial labs, spiking the bags, and titrating those drips milliliter by milliliter? That's us. The doctor can write all the orders they want, but those are just words on a screen until we make them happen at the bedside. You are executing the game-winning plays. So take this with you. Don't just memorize the steps. Understand the why behind them. Let it sharpen your instincts, because that clock, it's going to start ticking again probably on your very next shift. The enemy is out there. The only question is, who are you saving next?